The next patient is a 3.5-year-old Cane Corso, presenting with marked lameness in the left forelimb and recurrent buckling, particularly on the right side. In January and February 2024, the dog underwent cruciate ligament surgery, first on the right side, then on the left. Since April, persistent lameness has been observed in the left forelimb. Previous veterinary examinations included ultrasound, X-rays, and pain management therapy, but no significant improvement was noted. A platelet-rich plasma, PRP, therapy was suggested. Due to multiple past anesthetic procedures and a diagnosed epilepsy, the dog was referred to my practice. The gait analysis reveals a narrow stance in the hind limbs with a pronounced bilateral O-leg position of the knees. A pelvic twist is also evident. Additionally, the left forelimb shows significant irregularities, while the right forelimb is overloaded, leading to clear, stumbling movements on that side. When sitting, the left forelimb is positioned outward. A lateral view shows frequent buckling of the right forelimb, along with a so-called swing leg lameness on the left side. Furthermore, the pelvis is in a steep position, accompanied by lordosis posture and a sway back. Both knees show limited flexion due to the previous cruciate ligament surgeries. When moving in circles, an overbuilt pelvis, hypermetria, and compensatory overloading of the right forelimb are noticeable, further reinforcing the recurrent buckling. The left forelimb appears almost immobile, both dynamically and when assessing the shoulder area. The scapula shows little movement in either flexion or extension, indicating a severe functional impairment of the left shoulder. The orthopedic examination highlights a significant forward displacement of the left shoulder. Compared to the right side, there is restricted mobility and extension, while flexion causes noticeable pain reactions. Cranial translation indicates a downward shift of the limb. Overall, an asymmetry between the forelimbs is evident, with the left shoulder positioned lower. Notably, there is marked muscular hypertrophy of the right shoulder, which is visibly bulging outward due to chronic overuse. In summary, the left shoulder exhibits a forward and downward displacement along with slight internal rotation. Although the right shoulder remains mobile, it has become hypertrophic over time due to prolonged compensatory mechanisms, which contributes to the buckling of the right forelimb. Radiological examinations reveal slight mineralization in the intertubercular groove and at the supraspinatus muscle insertion. However, these findings are of questionable clinical relevance, as they commonly appear in dogs due to synsarcotic structures without causing pathological symptoms. Therefore, their clinical significance remains uncertain. Instead, the altered biomechanics of the left forelimb appear to be the primary concern. The cervical spine exhibits significant movement restrictions in all directions, particularly in flexion, extension, and lateral motion. The right forelimb also shows moderate movement limitations, which were confirmed through kinematic analysis. Ultrasound images provided afterward did not reveal any significant abnormalities, such as fluid accumulations in the bursae or tendon attachment lesions. The overall findings strongly indicate a biomechanical issue as the primary cause of the symptoms. The treatment involved orthopedic manual and kinematic adjustments. The left forelimb was repositioned by elevating and shifting it caudally. Additionally, manipulations were performed on the cervical spine to resolve biomechanical restrictions. Post-treatment imaging shows that the left shoulder is now aligned parallel to the right. A video analysis after the manipulation reveals a significant reduction in lameness. Notably, the buckling has almost entirely ceased, and there is an immediate improvement in both static and dynamic stability.